Thanks, Albert. So I am pleased to be here. I'm pleased to see everyone, whether you're interested in policy or the kidneys or kidney health policy. I think this symposium has been a long time coming. Basically, for me, seeing Albert next door to our offices and talking about kidney policy. So I'm glad that this has been sort of he's listened and thought this was interesting and worthy of a symposium. And I agree. Um, Kidney policy is so interesting because it's a microcosm of health policy in general. And I also want to thank the people who helped this symposium be possible, in addition to Albert, Dr. Latirapong, Dr. Concepcion, Dr. Barth from the Transplant Institute, and Dr. Chapman from Nephrology for your sponsorship. And so because of this, we've been able to assemble the dream team of speakers who are here to talk about kidney health and kidney policy. And we will start by introducing Dr. Michelle Josephson. So Dr. Josephson is a professor of medicine and surgery at the University of Chicago. She has served as the medical director of the University of Chicago Kidney Pancreas Transplant Program, as well as the program director of the Transplant Nephrology Fellowship. She completed both her undergraduate and medical school training at the University of Pennsylvania and completed her training in internal medicine and nephrology at the University of Chicago. She is the former president of the American Society of Nephrology and has served as a counselor and has been on the editorial boards of JASN and ASN, has co-authored many articles, and has an interest in live kidney donor, post-transplant bone disease, and pregnancy and transplant positions. She is deeply committed to education and policy within kidney transplantation. So, Dr. Josephson.
Can everyone hear me okay? Great. Okay, so it's really a thrill and honor to be here with everyone today. And I'm very excited to be talking to you about kidney care education and policies, a national review from ASN. Now, I actually thought I had more time to talk, so I actually do. But, so we've got a good amount of material to cover, and I'm going to try to do it expeditiously. Let's just say that. So I'm not going to go through every single thing that I'm going to talk to you about on this outline, but let's just say the following. If you got to put it together in broad strokes, it's like nephrology goes up, nephrology goes down, and then we're maybe back again. So you'll understand what I'm talking about as I get to this. So one question you may have is, who and what is ASN? So ASN, American Society of Nephrology, is a professional facing organization. It's a very large organization. We have over 21,000 members. And although our name is American Society of Nephrology, we're actually international. We've got members from over 140 countries. We're also extremely collaborative. Anyone, any organization that shares mutual goals, we're happy to work with you and talk with you. And that's actually been a lot of fun. We have a very audacious mission. Our mission is to create a world without kidney disease. And we do this as sort of an alliance. I don't have time to get to all of the specifics in the alliance, but there's a number of parts of ASN in this alliance. And we try to elevate care through education, through breakthroughs in innovation, which I'm really not going to talk about much today, or hardly any, and then policies, advocating for policies that create transformative change in kidney medicine, and that I'll touch on a bit. So what are we, like, what is our goals? What are we after? What are our priorities? Well, there was a membership survey and set of interviews that were done a few years ago, and we identified 4 priorities, which then became the basis for something called the Campaign for, or United for Kidney Health. And because we have 4 priorities. And I'm not going to talk about all of these. Obviously, they span a lot, including intervening early, accelerating innovation, achieving equity. And that certainly is a theme that runs throughout our work. But as a transplant nephrologist, I am going to focus a bit on transforming transplant. So that's in my second part of my talk. I want to sort of give you a background about the history of nephrology and treatment of kidney failure and how we got to where we are. And so I kind of termed this section, "If you build it, they will come." And so I want to jump ahead of myself. I want us to start at the beginning. We're going to look at history of dialysis and transplantation quickly. So if we go back to the first half of the 20th century, there were no effective treatments for kidney failure. In fact, kidney failure was a death sentence. That was until this gentleman, this Dutch physician, Willem Kalf, came along. Now, Willem Kalf was a really remarkable individual for many, many reasons. And his life's mission really crystallized when he saw someone die, a young man die slowly in front of him of acute kidney failure. And he decided then that he was going to build an artificial kidney to take over the function of the kidneys. If there was one word that I would attribute to Willem Kalf, it is perseverance. The guy was just unbelievable. And you know, it didn't bother him that people had tried before and had failed. He was on a mission and he was going to create this machine. Didn't matter that this was all happening in the middle of World War II. The Nazis were invading the Netherlands. Items and resources were very scarce. He had to improvise. I can't, sort of a fun story there. I don't have time to get into it, but he had to do a lot of improvising. His mentor, a physician by the name of Pollock Daniels, died by suicide to avoid persecution by the Nazis. So there's just unbelievable amount of challenges, but he kept going. And in fact, he finally did build a machine. And we would say, well, we all lived happily ever after, but that's not true. In fact, it was a dismal failure. The first 16 patients he dialyzed with acute kidney failure, it didn't help. Actually, I think 15 of the 16 died. One lived for other reasons. And it wasn't until this woman, a 67-year-old woman, Sophia Maria Schaffstadt, came in uremic coma. He dialyzed her with the Kalf dialyzer for 16 hours, and she woke up, and she went on to live for another 6 years and died of something else. And so that was really the beginning of dialysis, sort of. And I say sort of because it was the beginning of dialysis for people with acute kidney failure. There was no way to treat people who had chronic kidney failure because there was really no way to put in access to the vascular system that could be left in place until this gentleman, Melding Scribner, came along, and he made chronic dialysis possible by developing this Scribner shunt, as shown up here, where he connected the artery and the vein, which could be then left in place. That was fabulous, and what an incredible innovation. The problem was there weren't many dialyzers in the country, and who was going to pay for it? And consequently, in the places where they did dialyze, they had things like committees who were of lay people that were put together, I mean, this is a really difficult task to decide who would get dialyzed. They were really deciding who would live and who would die. They were not happy with their mission, but they were very committed to it. And if you read an article, which I encourage everyone in this room to read, it's an article by the name of a journalist named Shana Alexander. She wrote an article in Life magazine in 1962 because she went with this group for about 6 months and watched what they did. Anyway, they termed them God's Committee. And so that was the way things were until President Nixon came along in 1972. And he signed into law that Medicare would cover dialysis and transplantation. That is really the only universal health, what we want to call it, universal health allowance for anyone, for anything in the United States, but is directed towards kidney disease. Now, you may be wondering what motivated Richard Nixon to do such a thing. And so probably several things. One is that there was a committee that was set up, which several individuals were on, well-known individuals, and it was chaired by Carl Gottschalk, who was a nephrologist at UNC. And But perhaps if as important, if not more important, was patient advocacy. And so this is really demonstrated by this gentleman, Shep Glazer, who dialyzed in front of the House Ways and Means Committee in 1971. And he really tugged at the heartstrings of the congressman. Now, you may wonder, why am I saying congressman? Because in 1971, of the, I think, 435 seats in Congress, only 13 were taken by women. So needless to say, this was congressmen who made this decision. And because of, because of his advocacy as well as others, dialysis was, became a, something was available to all Americans, regardless of race, regardless of economy, regardless of geography. So it's really quite something. Okay, so that's dialysis. Now, despite the fact that we had chronic dialysis was really never seen as a forever treatment. It was sort of seen as a bridge to transplantation, which was seen as the better therapy, the therapy that everyone wanted to have. And in fact, Willem Kalf, the Dutch physician that I showed you, when he left the Netherlands and he went to the US, he came to the US and spent the latter part of his career here. He just spent some time in Boston working the Brigham with some of the physicians there who are putting together the transplant program with the intention of doing a dialysis program to get people to be able to be transplanted. And so transplantation as we know it, well, sort of as we know it, started almost 70 years ago in 1954. And this is an operating room in the Brigham where the first successful kidney transplant was done. It was performed by the Nobel Prize winner, Dr. Joseph Murray, and he transplanted Ronald Herrick's kidney into his identical twin, Richard Herrick. Now, I don't have time to go through all the details. Happy to answer questions about any of this later. But so this is where we see the world of kidney disease treatment as we know it now developing. So this was really an exciting time. Could you imagine? We've taken a disease that was fatal and turned it into manageable. We've got all this new technology. And so in the 60s, the 70s, trainees were flocking to train in nephrology. And, they could not be more excited about this area. And I wish I could say that continued. It didn't. So now we have sort of come into an era of unintended consequences when we sort of left the heyday, if you will, of nephrology. And, if anyone was at my address in Philadelphia last year, where I talked to about nephrology, I likened the early individuals in the nephrology space to heroes on an epic journey. And like all heroes and all epic journeys, they eventually face some kind of challenge or some kind of stagnation. And that too happened in nephrology. And sort of like Ulysses returning to Ithaca, there was temptation, things were not going so well. And that happened in nephrology. And so what does that bring us to now? Well, it brings us to a current state of affairs where we've got a tremendous number of Americans living with kidney disease. In fact, 15% of adult Americans are classified as having chronic kidney disease. There's over 800,000 individuals with end-stage kidney disease in Medicare, at least a few years back. I'm sure it's not any better now. And at that time, over 100,000 Americans began hemodialysis annually. And most importantly, African Americans are disproportionately affected by kidney failure. So where does that leave us? That leaves us with a system that we've created, all good intentions, we've created this system, but it doesn't really work well for the people that it was intended to help. And it's very expensive. This is a few years back, but it's really probably not any better, if not worse. You could see that that there's about 1% of the Medicare population is comprised of individuals ESRD, and yet Medicare spends 7% of its budget on ESRD care. So that's pretty bad. Let's just say. Anyway, and so there are consequences because the government's putting a lot of money into kidney care. and is not putting a lot of money into kidney research. And just to give you a sense, this is data from a GAO report that came out a few years ago that compared how the investment in kidney diseases compared to HIV/AIDS, cancer, and heart disease. You can see the prevalence. Kidney disease in the red at the bottom. You can see the prevalence is hugely greater with kidney disease, and the budget is much lower. And so the amount spent per patient is markedly under-resourced. And perhaps then you wouldn't be surprised to find that we've had much less innovation in this space. And just as an example, comes also from a few years ago. This is data that ASN put together, where they looked at the number of drug approvals in, for example, cancer space compared to the kidney disease space. It's pathetically disproportional. It's very problematic. So where does that leave us regarding treatment? Well, as I said, I'm a transplant nephrologist, so I'm going to say that we know that transplant is the optimal therapy, and the good news is that we really do continue to increase transplants and help individuals that we could never help before. But at the same time, we are failing many patients, and we have absolutely outgrown our system. I don't think anything illustrates so well how much we've outgrown our system than if we look at this graph of transplant access and the gap between supply and demand. In other words, the individuals who are on the wait list compared to those who are transplanted. Now, this is just the tip of the iceberg, because the truth of the matter is that that wait list line should be much, much, much higher, because there are many patients who would benefit from a kidney transplant who are never referred or who have trouble getting through the evaluation process. So we've got some issues, and we actually don't even have as much data about those individuals as we'd like to. So a lot of things that we have to work on. So what are our current challenges then? Well, we have a growing mismatch between supply and demand, as I showed you, and there are people who die every day waiting for a kidney. We talked about this a little bit last night. We've recognized, and I think Will's maybe going to talk about this. We're going to recognize the increasing percentages of kidneys not used. And we know that there's this whole other phenomenon going on now where kidneys are placed outside the match run, and that's got all sorts of interesting implications. Talk about that later if you want. And we've got a real understanding of the inequities in access, which disproportionately affects socioeconomically deprived individuals and non-white individuals. And we're hearing growing patient frustration. And so there's lack of transparency for the patients, but as Nita, growing the lack of transparency for the physicians trying to take care of the patients. And there's just this sense that the system doesn't work for them. Now, to add salt to that wound, remember that heyday of nephrology where I showed you everyone that was flocking into it and wanted to be a nephrologist? Those days are over, actually. What we see here is that we see that the ratio of candidates to nephrology positions have declined. And I think as any of us in the nephrology who are in nephrology sections, unfortunately know, many spots go unfilled, and we have the capacity and the need to train many more people than we've trained. Now, this is kind of all depressing. I really don't want to depress you this morning. So let me go to a more positive note and say, good news, the tide is starting to change. Okay, it's turning. So I said I wasn't going to spend a lot of time of innovation. That's right. So we had the down, as Elbert's showing, the down and the up of the kidney world. So we do have some good news in terms of innovation in the kidney space. We've got some very exciting drugs, SGLT2 inhibitors, GLP-1 agonists, the MRAs, which are being demonstrated to slow kidney disease progression, potentially putting off inevitable ESKD, or for some people, maybe they never hit ESKD. Wonderful new antihypertensives, new glomerulonephritis therapies, very exciting. And we've got genetic testing in a way that's going to enable us to say what patients had in the way that we couldn't before. And maybe arguably, but we have advances in xenotransplantation. We were joking last night that I've been in transplant a long time, and the joke was always xenotransplantation is the future of transplantation. It will always be the future of transplantation. but maybe, maybe not. Who knows? We can hope. Okay, but I'm here not really to talk about innovation. I'm here to talk about policy. So let's turn our attention to policy, and say that the ASN has worked very closely with the Obama administration, the Trump administration, and the Biden administration to affect positive change in transplant. And we are really advocating to expedite clear government reforms necessary to maximize patient access to transplant and enable more use of organs. And so over the years, there's been a lot that's gone on, and this has somewhat resulted in something that happened in 2019 when President Trump put forth the Advancing Americans' Kidney Health executive order. Now, Trump didn't come up with this. This was actually developed by Alex Azar, who was his secretary of HHS, and he had his father actually had kidney disease. So this was a very personal thing for him. And he saw the kidney world didn't really work for patients. And so he really worked to say we need to reduce the risk of kidney failure, improve access to, and the quality of person-centered treatments, very aspirational goal that by 2025, which is like 3 months away or something, we were going to have 80% of patients who initiate renal replacement therapy on dialysis at home or undergoing a transplant. That's not going to happen, but it's always good to have an aspirational goal and to increase the access to kidney transplants. So very exciting changes and a challenge, really a challenge to the kidney community. And I think the kidney community has stepped up to that challenge because there's just tremendous amount of innovation and policies and things going on in the kidney space. And I like to call this kind of the alphabet soup of initiatives in transplant. I don't even have I just realized last night I left off ETCLC. There's a lot of other acronyms that I could put on there. And I don't have time to talk about all of these, but I want to touch on a few of them to just give you a flavor of how much is going on in the kidney space. So let's start talking about OPOs. Now I'm showing you this nice map and you may be thinking, well, that's a really pretty color-coded map of the United States, and look at all the states with different colors, but that's not what this is. This is actually a color-coded map of the OPOs, organ procurement organizations in the US, the 56 organ procurement organizations. What are OPOs, or organ procurement organizations? They're not-for-profit organizations. They're responsible for recovering organs from deceased donors for transplant in the US. And this is a federally, they're mandated by federal law to perform this mission. They have specific area, the donation service area, and they're also involved in allocating the organs. Now, OPOs are in tremendous amount of pressure these days. Why? Well, because in 2020, CMS issued a final rule in which to update how they would cover OPOs, and they decided to establish a process to decertify any OPO that falls below a median performance on 2 specified metrics for this calendar year, 2024. So there's a lot going on in the space right now in 2024. And we haven't actually heard the metrics yet. Tom might know the metric. I don't know if he does or not, but Tom, he's not talking every time. Anyway, I don't know if he knows the metrics that are gonna be used, but there are evolving metrics that we're hoping will fairly hold OPOs accountable to serving their communities and enable us to have more organs. But OPOs are not the only group that's under a lot of pressure. So turns out that UNOS is under tremendous amount of pressure. Now, what is UNOS? UNOS is the contractor for the OPTN, or the Organ Procurement Transplantation Network. And the OPTN is something that was mandated in 1984 by Congress to really oversee and run the transplant programs nationwide. And they decided to have a contractor, a private, not-for-profit private contractor. And UNOS won that contract in 1986, and they've held that contract ever since. Now, supposedly, Congress was going to oversee functioning, but I can't say they really did so well, but they got very upset in the last few years about how things were going, how UNOS was functioning. And so this led to actually 3 Senate finance hearings. And I saw the first one, and it was explosive. For anyone who doesn't like conflict, or this is not the thing to watch, I'll just say. And this is kind of how I'm understanding this is kind of how they do things. They are very intense and explosive. So you may be saying, what are all these angry senators talking about? And really, they were talking about our nation's transplant network. And just to give you sort of a flavor of this, I want to read the beginning of what Ron Wyden, who's he was the chair of this chairman of the Senate Finance Committee, and he ran these hearings. So I just want to give you a flavor of how he opened things up. The last place anybody wants to hear about gross mismanagement is in the business of saving lives. He then went on to say, far too many Americans are dying needlessly because UNOS and many of the transplant organizations it oversees are failing and seem uninterested in improving. And I can't say that what they said got any nicer or better. But it led to change. Just going to say that it really did lead to change. And so about a year ago, President Biden, here is a picture of him signing into law the what's called the SUS-OP10, or the Securing the U.S. OPTN Act. You may say, well, what the heck is that? Well, so the Securing the U.S. OPTN, or SUS-OP10, is basically a law that enables things to happen. It's like a framework law. So it gives an opportunity for improvement. So for example, it eliminates the rule that the contractor be a not-for-profit, although some of them have to be not-for-profit, organization with prior expertise in the OPTN contract scope of work, because otherwise only UNOS could win the award. It said that they could break up this contract to multiple bidders. And so it didn't have to be a bidder that was able to take care of everything. Someone could be expert in one area and get a contract and not in another area. And that's actually what they're doing. So current HHS Secretary Becerra is in the midst of awarding contracts to various bidders. This is happening right now. It also strikes how much money could be that could be spent on the OPTN contract amount. So it enables them to do a little more resources, financial resources, and it changes the governance such that the governing body that oversees OPTN is not the same government body that oversees the contractor. So there is a little bit better governance. And the point of all of these changes is to enable something called the OPTN Modernization Initiative, which is supposed to be a patient-centered approach to transplant to improve areas of technology, data analytics, governance, and operations. So very, very, very exciting. And we are in the midst of a lot of change, I'll just say. And we're in the midst of a lot of efforts to make change. I don't have time to talk about any of them or all of them, but I do want to mention one, and Tom's going to talk about this one a bit later, which is the CMS or CMMI's initiative called IOTA, which stands for Increasing Organ Transplant Access. It's a mandatory model, and it's aimed at transplant hospitals. And the purpose is to increase kidney transplant, both through deceased donor organ use, as well as helping and improving living donor transplant. And this is done by a carrot and stick model of incentives and some disincentives if you don't meet what you're supposed to be doing, with the intention of increasing equitable access to kidney transplant, improving quality of care before, during, and after transplant, improving care coordination, and reducing Medicare expenditure. If you want to know what ASN's position on this is, we're very much in favor of these principles, and we're very optimistic and hopeful that this is going to be a good thing. But the devil's always in the detail. And as Tom and I were joking last night, we know that ASN sent CMMI a 50-page letter of a few suggestions that we thought would help. We'll see how many are embraced, but anyway, time will tell. So where does this leave us, and what does this all mean? Well, it means we got a lot of balls in the air. We got a lot of stuff going on. I didn't speak about half of it in the transplant arena, but to be fair, when ASN started talking about its interest in transplant some years back, we said we needed to have a lot of simultaneous change at once to really improve the transplant area, because there was no one silver bullet. So you might say, be careful what you wish for, and that would be true. The other thing I want to say is not everyone is so happy about these changes, and change is very hard. But I would also mention that Alex Azar came to the American Transplant Congress last year in June, and he was at a plenary session. I listened, and he basically said, this train is leaving the station. Your choice is get on it or be left behind. You might be unhappy, too bad, it's going forward. I would phrase this a little differently. I would say the following. I would say, if you're interested and you want to help direct the train, join us on the train to help make sure it goes in the direction you'd like. But it is going forward. And so this is not stopping. So then I remember I showed you that we didn't have enough people to provide care because we had decreased amount of fellows entering the area. And unfortunately, we've had a decreased interest in general nephrology, nephrology nursing, and transplant nephrology over the years since the heyday. We're no longer in that heyday, as you can tell, but maybe a new heyday to come. And ASN has been very cognizant of this issue. And so in a couple of years ago, they put together a task force to try to improve how fellows were trained, to excite people about going to nephrology, and also to update nephrology training so that it looks more towards home dialysis and home care approaches. And we were also collaborating with the American Nephrology Nurses Association in several regards. One, to help them with trying to interest nurses who are either training to become nurses to go into nephrology, or those who are already in the nursing field to consider pivoting a little bit to go into nephrology nursing, as well as to work on some innovative and interesting educational opportunities for nurses so that they can get a lot more education in nephrology. The other group that we've been working with is the American Society of Transplantation. When I was president, I had the great honor of meeting on a regular basis with Dupali Kumar, and then with Josh Levitsky, who were the presidents of American Society of Transplantation. We all recognized there were not enough transplant nephrologists, and we needed to improve it. And this lack of transplant nephrologists was happening as the transplant numbers were growing. So this is before we even put any of these efforts into place to try to increase transplantation. I think it's hopefully only going to increase further. And to make it even harder, if you look at other sort of comparable transplant areas and look at the number of transplant nephrologists versus transplant cardiologists, transplant hepatologists, to the number of patients that we have to take care of, it's just totally disproportionately under-resourced with respect to transplant nephrologists. We desperately need more transplant nephrologists, and we've known this before we even started our efforts to increase. So, there's no perfect way of doing this, but one of the things that we talked about, and especially with Josh Levitsky, who found that for transplant hepatology, ACGME accreditation of their transplant hepatology program really helped them to increase interest and improve and increase transplant hepatologists that may be, pursuing ACGME accreditation would help. It would potentially increase visibility. It would potentially increase the level so that residents could have more visibility to the residents, to the hospital. It would also potentially give a pathway to federal funding through GME training. not a perfect solution, but potentially good. And so the good news is that we just found out about a little over 10 days ago, almost 2 weeks ago, that we did get ACGME accreditation for transplant nephrology. Not going to happen this year, but in the next few years, we're going to be rolling this out. It's going to go into place. So that's very exciting. Obviously, we don't know if this will help, or hopefully it will help. And hopefully with many changes, we'll have improvement. So as I finish up here, what I'm going to say is that I think you've gotten the idea that there's a lot of pieces going on at once. And if you go into government and you look at how nephrology policy and care is dealt with, it's very much fragmented. It's sort of like a piece of glass that you break, very, very fragmented. And so government's not totally holding all of the pieces together, and we'd like to get these pieces back together again. So ASN, I'm going to end with this sort of bold initiative. ASN has come up with sort of bold concept and initiative of what we need is an HHS officer of kidney health and transplantation to lead to a unified approach to kidney health. Sort of a concept. We're going to elevate, this person will be reporting directly to the HHS secretary. And just circling back to the beginning of the talk, this would then uphold the commitment made by Congress to people with kidney diseases, setting a strategic vision, fostering cooperation, and aligning kidney health policy across HHS. So it's an exciting, audacious idea. We'll see where this goes, but it's I think it's got promise. So with that, I will stop here, and I'll thank you very much for this opportunity to talk. And I take the questions. I don't know. Hey, I got it, and I did it.
You had a slide about the straining the station. To what extent is some of the pushback purely just because of self-interest that the winners in the car system losing versus there being substantive issues with the new policies that are being rolled out?
You bring up a critical point, and I do think that there is a lot of concern and that anyone's, I think there's concerns on multiple levels, but one concern is certainly that the winners, the current winners may not be in as good a position as they are in the future. There's also concerns. I didn't get into all of the details about some of the work imposed on centers by some of the changes. So for example, I didn't have an opportunity to talk to you about how, and I don't know if any of the other speakers are going to chat about how there's not great transparency for patients in the system, and how, for example, we were saying last night that like 16 or more offers could be made to someone waiting on a wait list, and they don't even know that that kidneys are being turned down on their behalf. And they, may die waiting for a kidney transplant, but there've been kidneys that have been turned down on their behalf because, quote unquote, they're not perhaps good enough. And so I think there's a lot of concern that we have to then figure out how to notify patients about these, and what is that going to entail? Is there enough time? We're already stretched thin, both in terms of workforce and in terms of workload. How are we going to be able to put these, these issues into play? But I think the issue of self-interest is always an issue. And I also think, some people feel, and getting back to that slide where I said, we're talked about, we're being, we're really doing a lot. We're improving transplant. Many people feel, and we probably are, the best transplant program or the best transplant organization in the world. So people have said, well, we're the best in the world. So, why do we have to change? Because even if you're the best in the world, you could do better. I mean, it's arguable, but even if you're the best in the world, you could do better and you could improve. But I think there's just a lot of concern. And I do think that there was also concern, for example, of giving some of the contracts to not for-profit organizations, thinking about what that would entail. Not all of the contracts are for-profit, but that was a big concern. And I do think there's going to have to be oversight. It is going to entail a lot of oversight to make sure that, a contractor that's for profit isn't doing it for the wrong reasons or doing things for profit as opposed to in the patient's best interest. So I think there have been concerns for multiple reasons, but ultimately, I think the point you bring up that self-interest in there's always self-interest in many, many different areas. And I think that absolutely always plays a role.
Thanks for a really interesting talk. I'm Tamara Konecka. I'm a health economist and also a MedPAC commissioner, so I'm intensely interested in Medicare payment. And I'm wondering what the lack of interest by providers in going into nephrology, to what extent is that driven by a lack of interest in the substance versus Medicare payment policy, and whether providers just don't find that remunerative enough?
No, you bring up a really excellent point. So, I think there's two parts. One, the material or how the material is presented to medical students and residents. And then the other point is that there's a perception that nephrologists work really hard and aren't paid well enough, and that doesn't help. Especially, I would say, in this year, it just doesn't help. And so actually, that is one of the things that ASN is working on, is to try and work out that working with, actually trying to work with the AMA and get on something called the RUC, which helps with payment, and to try to improve that. It's not going to be anything that's fast, but that is definitely one factor.
So Michelle, you described all these policy changes happening at the same time. Do we have the data systems in place to evaluate and disentangle what policy is doing what to people?
So I'm looking at Will Smile over this one, but I think there's absolutely some problems with some of the data systems, and I would point specifically to the fact that we really don't have a great data system for before people are transplanted. And actually, this is something that ASN and I'm speaking as ASN. I mean, a lot of people are working on this. Yeah, and so they are absolutely working very hard to get the data systems in place so we can get more granular information about who's referred, how, what units are they referred from, what is their socioeconomic status, who's staying on dialysis. There's a lot of information that we need to drill down into. So the answer is no at this point. We really don't have all of the data systems that we could use, but this is an area of great interest, and I believe that that is something that is being addressed.
I have a question. So I'm always saying how, kidney health is a microcosm of health policy in general. To what extent do you think some of the issues in nephrology or in transplant nephrology are unique to its, sort of funding and players versus emblematic of the health policy in general? We just happen to have data on it in nephrology or in end-stage kidney disease.
I think yes and yes. I think the answer is there's no question that part of what goes on has to do with the funding and the way it's set up. But at the same time, so there is some unique features, but at the same time, I think it is kind of a little bit the bird and the canary when you think about. I mean, just if you went to dialysis units during COVID, I think it was really reflective of what was going on in other areas, and other, so really peeling back. I think it's actually interesting. I'll actually expand on that a little bit. Peeling back what is going on in other arenas where people are socioeconomically deprived, who maybe there's not as much contact with these individuals in the healthcare system. So I think it is reflective. I mean, the other interesting part is that nephrology has been reflective in another arena when we think about the issue of our blindness to racial inequities over the years, our blindness to, I mean, just take the EGFR calculation and how it really, I would say it took medical students and it took nephrology to really identify that, wait a second, why do we have, why is this race factor in there? And then, and whatever you're feeling about the accuracy of the equation, I would say that, it really was a wake-up call and a recognition, which has really, I think, galvanized other subspecialties, pulmonary, cardiology, many other subspecialties to start to look at their equations and assumptions. So that's a little bit of a tangential, but just to say yes to both. It's one, it's partly having to do with policy, but two, we are kind of a microcosm of what goes on in other disease areas. Yeah. Okay, thanks so much.